Good afternoon, and thank you everyone for attending today's webinar, Helping Physician Practices Understand and Comply with New Narcotics Prescribing Guidelines, brought to you by Brian Kern and John Maroney of Friar Levitt. Please be aware that there will be a question-answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question-answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar, and a recorded version will be available on the website for members only. Again, NJMGMA would like to thank you for attending, and I will now turn things over to Brian.
Hey, good afternoon, everybody. My name is Brian Kern. I'm of counsel with Friar Levitt. And previously, I was the Northeast Regional Director of Healthcare for Arthur J. Gallagher, which is the 4th largest insurance brokerage. So the first part of this presentation will focus on liability, which of course is my background. And the second part will be presented by John Maroney, who is probably the guy to give this presentation. He is an attorney and partner with Friar Levitt. He is the former head of a healthcare system. He is also a nurse, and he is also an EMT and a first responder who has been dealing with Narcan and overdose for decades and is really immersed in this topic. So hopefully we'll get a lot out of this. You may also be aware that we're doing a quarterly seminar. There's one on April 28th in Deptford, and there's one on May 5th in Islin. And some people suggested that maybe there's not enough information on opioids to fill these quarterly topics, and I promise you that's not the case at all. We have so many different issues. We're going to try and give as much as we can in this hour and as much guidance and help as we can, but there's so much from society and public policy and the history of the legislation and the enforcement activity and the intent and hope on how to deal with opioids and addiction, that hopefully everyone can make it to one of the quarterly events. We have the COO of MSNJ who's going to be a panelist. On 428, we actually have 4 female panelists, so we're pretty excited about that. And yours truly will be moderating. I'm sure everyone read diligently that disclaimer, and here's a little bit about the firm. But to start any opioid presentation, you have to start with statistics because they're staggering. Just look at these numbers, $55 billion a year in healthcare and social costs related to opioids, $20 billion in emergency and inpatient care, and we're going to come back to that number because that is pretty incredible. Every single day, 650,000 opioid prescriptions, 3,900 people initiate the non-medical use of prescription opioids, 580 initiate heroin use, and 78 people now every day die in opioid-related overdoses, which is more than car crashes, and hence why this issue is so commonly now being called an epidemic. More statistics. U.S. consumes 90% of the world's opiates, even by United States measures. That's a lot. 1/3 of all opioid prescriptions are being abused. Now, that's a strong statement. That's from Castlight Health, but I've also seen that statistic quoted quite a bit, and that really frames this issue in a different light. Arguably, if you accept this, that means 1/3 of opioid prescriptions are potentially negligent, and that's what we really need to be concerned with. When we get to the challenges of this issue, though, there's no simple solution to anything that we're proposing. There are so many different physicians that can prescribe and, consider themselves the treater of pain and problems. And part of the issue is it's hard to identify what pain is. Now, I have a friend, and we were just at lunch last week, and he was telling me that he had back surgery, and he still had pain after the surgery. He went to his orthopedic physician, or I should say he was prescribed after the surgery 80 Percocets, and he finished them. He went back to his orthopedic surgeon, who said, there's really no good surgical solutions at this point. I'm going to refer you to a pain management physician. After taking 80 Percocets, the pain management doctor gave him a prescription for 120 OxyContins. He took the prescription to the pharmacy. The pharmacist questioned him and asked him why he needs 120 OxyContins, and he said, I don't know. This is what he gave me. Should I take less? And the pharmacist filled the prescription, and he took the 120 OxyContins on his way, and that was the end of it. And, you know, again, we're back to this issue. We can't just take a test. We can't just take an X-ray and determine levels of pain. We have to, you know, we have to agree or treat what the patient is telling us the pain is, and therein lies some of the problem. We want to treat patients, and we can choose not to treat patients, but that has risks. We can't just turn patients away. And I think part of the impetus for this problem was long ago, because back in 1991, $15 million was awarded to the family of a patient who was dying, and the physician was said not to have been compassionate enough and should have given more pain medication to this dying person. $15 million award. There's several, but there was another one in 2001, $1.5 million around this particular issue known as compassion in dying. But it was around this time that guidelines and physicians started to be encouraged to treat pain. So if patients came in, they should be given pain medication. And now we're starting to see problems with it, but you can't just terminate a patient. You can't just abandon the patient. There's a process, there's a protocol that you have to go through to terminate patients. And even worse, you may terminate a patient and you're part of an ACO or a clinically integrated network, and it turns out this patient is seeing another physician, so you're still responsible for the shared savings associated with the patient. I think about the parents who take their children to their pediatrician and don't get a prescription for antibiotics, and they're not satisfied. They take their children to the pediatrician because they want treatment. If they take the antibiotics, satisfied, they pass the patient satisfaction surveys, they get high scores, and everybody's happy. I really liken this to the opioid epidemic. Patients are showing up to the physician practice. They want medicine. They want to be treated. And, of course, the other issue is patient goes to get opioid treatment, has pain, the doctor prescribes nothing, and before you know it, you're on social media, and the patient is accusing the physician of not being sympathetic and, you know, a bad person. So there's so many issues associated with just turning a patient away, and it's not that simple. But I think where there is enormous opportunity is in this shared savings world. Again, $20 billion is spent annually in opioid emergency department and in inpatient care. What an opportunity to be the practice that has a standardized, really high level and trackable protocol to deal with patients. The ones who are in pain and haven't started taking opioids potentially and need care, if you have a great pathway to deal with those patients so the big expenses are not coming down the line, or for the patients who are already on opioid treatment, trying to figure out how to taper them off or to avoid addiction down the road. There's new laws, John's going to touch on this, but there's now mandatory inpatient treatment for patients, and payers have to pay for it. So if you consider the amount of money that you can save by keeping them out of a 6-month treatment program, if you can carve into that $20 billion of savings annually, if you can reduce medical costs, there's so much potential shared savings. But also, I think you can go to the payers and just make an argument that we're going to save you money. You should be able to see that our patients are requiring less opioid treatment and you know, should be successful. And I get negotiating with payers is not the simplest thing in the world and may not be possible, but I think there's hope. And I think we're getting to the point where you may be able to demonstrate or may be able to get information to show definitively that the way you're treating patients is beneficial and reduces costs. And hopefully you can take part in that shared savings. So standardizing practices are great for all kinds of reasons. especially in the negligence world. This is a huge emerging issue. I mentioned the statistic, a third of prescriptions are being abused. Does that mean that they're negligent? Well, many would argue no, but plaintiff attorneys are paid to argue yes. So they're really seizing on this to say, this is a problem. Physicians are the cause of this problem. And look, they're overprescribing by a third. So this is something that we need to deal with legally and through negligence, through medical malpractice litigation. The breach of duty, if you accept that one-third statistic, is not hard to establish in a case. Causation, think about it. It's not hard to establish. Did negligent prescribing lead to addiction? Well, sure. The patient is now addicted, and it started with a prescription that the doctor gave this patient. Not difficult to prove, especially in front of a jury. Damages, that takes us right to damages. Patient lost his or her job, is out of work, is no longer able to make an income. Cost of treatment, cost of rehab, yes, maybe it's covered. Cost of uncovered treatments, cost of copays and deductibles and everything else, not to mention the pain and suffering associated with these kind of issues to the family, to everybody else. And this is a very sympathetic issue for the jurors. You made me an addict. You caused all these problems. You're the reason I'm here. Plaintiffs are really taking note of these cases because they like them, they're winnable, and they love a sympathetic jury. And this all just screams out for the same standardization that may be able to get you more income. It can also keep you away from all of these issues. Develop good policies and procedures. John's going to go into a little bit about how to do that and compliance tools and stuff. But it's time to do this, and I think there's opportunity and protection in doing it. There's a lot of other charges out there associated with opioids. Just in New Jersey, March 2nd, 2017, it was reported a doctor was engaged in, allegedly selling, and I say allegedly not just because it hasn't been convicted yet, but oftentimes you'll see that these charges are much worse than what really happened. But who knows? Maybe this physician was engaged in this. But listen to these charges: strict liability for first-degree drug-induced death, money laundering, conspiracy, unlawful distribution of OxyContin, also within 1,000 feet of a school, fraudulent tax returns, and failure to pay income tax. Those are not pretty charges, and those are not covered by malpractice insurance. So, be wary of these charges that can come if you don't take proper care of your records. A murder charge. In California last year, you may have saw this, the first ever murder conviction for a physician. Now, I read this case, and it was heartbreaking to hear about all these patients who submitted letters to this physician saying, my relative is going to die if you keep prescribing. They're really, really sick. Please stop doing this. There was several accounts, testimony at trial along these lines. The physician kept doing it despite these letters and these suggestions. So, maybe in this case, this was deserved, but it just shows that there's a lot more than just medical malpractice out there. And also prescribing without good faith exams. Make sure you're doing a proper exam before filling prescriptions, doing prescriptions. It also gets potentially into the area of a false claim. Is it a worthless service if all you're doing is filling a prescription? So just something to be aware of. And again, the government is all over this issue. And the reality is there are times when patients need pain management. And it's important to be able to treat patients and feel comfortable doing so. So we're always come back to good old record keeping, good old documentation. It's always where we start everything. But in this context, it's important because this is what the government turns to first. Whenever there's a bad outcome, the first thing they want to do is pull charts, read the charts, and figure out whether there was proper documentation, whether there was proper justification. And this is the opportunity, again, to develop practice-wide protocols, standardizations, and procedures that can help in so many different ways. Patient contracts, you've probably heard of. It's a great tool used by many pain management physicians. Patient comes in, signs a contract, signs an agreement, agreeing to only see that physician for pain management. They'll undergo drug testing. They won't take any other drugs. There's a whole list of things that the patients agree to do as part of the engagement. So it's great if you can implement that into your practice. It would be great. Government has done this for a while, but I've heard more stories of late of the government sending in fake patients to practices and trying to get opioids, essentially, is the goal. And part of the problem is they're not unsophisticated people they're sending in. And, you know, doctors are very busy. They're seeing many, many patients. If these people are savvy at getting drugs, can seem unfair that this evidence is then going to be used against the physician. And, you know, you hear the term security risk analysis with all the crazy cyber problems now and hacks and attacks. So you do a security risk analysis. Maybe it wouldn't be such a bad idea to send a fake patient into your practice on your terms to see if they're able to get opioids. Pick one of the more compassionate physicians who, you know, may be more susceptible to this kind of thing, and then see how that plays out. There was a story that I heard recently that one of these fake patients brought an X-ray in, an MRI in with them, and it was an X-ray of a dog, and they used this to get an opiate prescription. And of course, this is not something that you want before a jury, but at the same time, you know, consider you're a physician and a patient is bringing in X-rays, claiming to have been to a physician in the past in a lot of pain, and, you know, the prescription follows. So you really have to be sensitive to these types of issues and these governmental enforcement activities, especially if you're a practice that treats pain. I mean, there's a lot of them. So if you are one of those practices, really take more care now to what's going on. Another red flag is a negative urine. If there is a patient who is being treated for opiates and they signed a contract, they said they're only going to take this and not other drugs, and you test them, and yeah, great, they're negative for all these other drugs. Well, they're also negative for opiates. That's a big red flag, because these patients may be taking these opiates and selling them, and you can be pulled down into that investigation. That goes back to the money laundering and distribution type claims. So a lot of people say this can never happen to me. I'm certainly not going to be charged with murder. You know, we're much more responsible than that. Our documents are okay. But just last year, just in New Jersey, 31 physicians were sanctioned for overprescribing. So the issue is real. It's something that needs to be addressed. I think it can be addressed responsibly, and I think most practices probably can continue operating just the way they do, but by tightening up some controls and by maybe improving some documentation and by, you know, education, calling a meeting and explaining what the issues are and dealing with them through documentation and through discussion with patients. So with that, I'm going to turn it over to Mr. Maroney, who's going to get into a little more depth on guidelines and origins of these of laws and how you can protect yourself against them. Thank you.
Hi, good afternoon, everyone. Thank you for joining the conference, and thank you to MGMA for allowing me to speak to you folks. So Brian has given you some of the pitfalls in opiate prescribing, and as everybody and anybody that has any contact with the outside world has seen, that truly the opioid epidemic is top of mind. You have the president speaking about it, you have Governor Christie speaking about it, you have the CDC and a variety of other organizations speaking about it. And it comes with a variety of different problems: financial, social, and clinical to the patient, and risk to the prescribing physicians, who are put in this conundrum of how to treat patients with chronic pain effectively, while at the same time not creating individuals who are addicted and go on to have worse problems. So one of the outcomes of the opioid epidemic was a very extensive guidelines published by the CDC on the management of chronic pain and the utilization of opioids. Now, these guidelines were essentially directed more so at primary care physicians, as more than 50% of the opiates that are prescribed by primary care physicians. And that is not necessarily a rub on primary care docs, but the reality of the situation is that primary care physicians are typically very busy, see a tremendous number of patients, as their practice is primarily office-based, and they're not usually formally trained in pain management as some of the other clinical disciplines, particularly anesthesia and physicians that have gone through a pain management fellowship. So some of the guidelines that the CDC has promulgated is to not go to opioids as the go-to pain management treatment, but to use other non-pharmacological treatments such as cold therapy, non-opioids just as NSAIDs, and over-the-counter meds, and then go to opioids. As Brian mentioned, the use of a contract, establish treatment goals, communicate with the patients, and provide what their goals are. Folks very often go to the physician and expect to get a pill and have all of their problems go away. It may not be a total alleviation of pain. That may be an unrealistic goal, but it's a mitigation of pain to make it tolerable. But the creation of a contract with a patient and management of expectations. So also the actual prescribing of opiates, and starting with the lowest dose, selecting the right type of opioids, collaborating with pharmacists to determine what the best approach is. A big one is the duration. Is Brian gave an example of a surgeon just providing a 1-month supply of medication. New Jersey, and I'll speak a little more about the law, but has changed the law about initial dosing of opiates. New York has had it on the books for some time, is that for acute post-operative pain, it's very rarely prudent to just give a patient a 30-day supply of a narcotic, but rather a 5 to 7 day initial dose, and then once the patient has gone through that initial course, the physician is to reevaluate the patient and then determine the follow-up treatment, whether it's going to be opioids. Also assessing and understanding when it's time to turn a patient over to another clinical discipline. If a patient is on opiates and is being managed by a primary care doctor or an oncologist or any orthopedic surgeon, and they don't have a solution for that patient's pain within their clinical discipline, and opiates are not meeting the expectations or the goals, it's time to turn to the interventional pain physician, because there are other options such as spinal stimulators and implants and other non-opiate based interventions. And then the last thing, I'm not going to go through the slides slavishly and go through each and every bullet point, but the use of prescription drug monitoring programs and assessing the database, the New Jersey State database, when you're prescribing, to see, are patients doctor shopping? Have they, although they've come to you and you may think that you as the physician are writing for the initial prescription of an opiate, you find that the patient has been to several other physicians and has in fact been on opiates for some time. There have been specific laws created. In 2013, there was the New Jersey Overdose Prevention Act that codified some of these actions that I've spoken about even before the CDC came out with the guidelines. So the latest revision to this law, which is very important for all the practices to be aware of and to comply with, is that a practitioner shall not order an initial prescription for an opiate that exceeds 5 days supply for acute pain. That's what I was speaking about a few minutes ago. That you have a patient that particularly post-operative acute pain, that a physician in New Jersey can conceivably be charged with professional misconduct if you just write for a 1 month supply or indiscriminately order opiates. Also, that as part of the process of prescribing, that the physician or the other healthcare professional discuss with the patient and the patient's family the risks of taking opiates. And, much along the lines of the usual informed consent for a procedure, is that the expectation is that you, as a physician, explain the risk, benefits, and alternatives to taking opiates. What are the other options for the patient rather than just an opiate, and what are some of the long-term risks of taking opiates? Now, one of the areas that has emerged and creates both a benefit to society and addicted patients, but also creates, to my mind, a significant risk for physician practices as well as pharmacy practices, is the use of naloxone. So naloxone has been around for a long time, as have I in the healthcare field. I was a young paramedic in New York City back in the early 80s when heroin was rampant, and that was when Narcan, as it was known, as first emerged, and it truly is a revolutionary drug and saves a lot of lives because it reverses the effects of opiates. Fast forward now to 2016, 2017, and naloxone is being put in the hands of other first responders, not just paramedics, but EMTs, police, fire, that the drug can be administered either via an auto injection or various nasal forms by folks with a modest amount of training. Even family members can be trained in the use of naloxone. So the New Jersey statutes now allow for the provision of opiates to family members, to other people associated with potential victims of opiate overdose. And there is a safe harbor or a Good Samaritan component to this law, that basically anyone acting in good faith, providing an opiate antidote to a suspected opioid overdose victim would not be prosecuted or civilly or criminally or suffer any type of professional disciplinary action for their good faith efforts. So the next thing that we turn to is where I see a potential malpractice risk for the physician is when prescribing opiates, if a patient is at risk of a overdose. So, a patient that has a long history, may have in other prior medical history of addictions, of alcohol, or has been known in the past to use street drugs. It's almost, and I think will become the standard of care to prescribe naloxone and educate the patient's family and those around them about the use of naloxone. I can envision, plaintiff's attorneys looking at this and taking on cases where patients have overdosed and died from prescription opiates, and putting a physician on the stand and say, doctor, do you know what the drug naloxone is? Do you know what it does? Could it have saved this patient's life if somebody had administered it? And the physician would have to answer in the affirmative. And then the big question that the plaintiff's lawyers would be salivating over is, well, why didn't you prescribe naloxone when you wrote that 120 pill prescription for this patient? One of the other areas of to know about with naloxone is standing orders. In the states of New York and New Jersey, there's now the ability to provide non-patient specific standing orders. Some of these can be issued by pharmacies directly. We also represent a number of pharmacy clients. This also creates a liability for the pharmacy clients, in that when a patient presents with a prescription for an opiate, particularly a significant amount, what is the duty of that pharmacy to question it and just dispense Narcan or naloxone under the standing order provisions? It also creates a liability if that pharmacist doesn't call the physician and say things like, this is a big, a significant prescription that you've written for this patient. Is there a particular reason why the patient hasn't been issued a complimentary prescription for naloxone? So we view this as almost, although these laws were put in place to benefit patients and providers and give providers more freedom, it has also created a significant duty for the providers. What I want to talk briefly about is something called turf REMS, and this is something that many people, even pain management physicians, were not familiar with. But the REMS program is an FDA program that stands for Risk Evaluation and Mitigation Strategy. And the FDA will approve drugs only within this program because for a variety of different reasons, the drugs are very risky. TURF, the acronym TURF, stands for transmucosal immediate release fentanyl. And that the F word here, fentanyl, is another top of mind word in politics, in society today. Fentanyl is an extremely powerful drug. The TURF REMS program was initiated primarily to provide patients that are opioid tolerant and have breakthrough cancer pain a means of relief. And these drugs within the REMS program were limited to breakthrough cancer pain. Now, the reason that I bring this up now and why it's significant to this discussion is that there's a variety of different drugs that fall within the TURF REMS program. One such drug is called Subsys, and it's manufactured by a company called Insys. And Insys used a variety of different marketing techniques to get physicians to prescribe the medication off-label. And a number of patient deaths occurred, and a disproportionate amount of the drug was ordered for off-label use, which means that it was for patients that did not have a cancer diagnosis. And there are two significant government investigations going on that have swept within their ambit physicians and pharmacies and the manufacturers of Insys. To date, I think it's a half dozen of the former executives of Insys have been charged criminally, along with 19 prescribers for their role in a government-alleged conspiracy to dispense this medication off-label, resulting in harm to patients. The government is being so aggressive in this that FBI has taken the unprecedented step of posting on their website a call to patients about Subsys and asking if you have been prescribed Subsys to fill out a questionnaire, and an FBI agent or two will come and interview you as the FBI is pursuing criminal cases against prescribers, pharmacies and the manufacturers of the drug. Not to be undone, the Attorney General in the state of New Jersey has also issued a posting on their website for consumers that were prescribed Subsys. A number of physicians in the state of New Jersey have been charged, so far not criminally, but by the Board of Medical Examiners. Some have entered into consent agreements because of their prescribing patterns of Subsys and their relationships with Insys. And in one situation, a patient actually died, and I believe in that case, the medication was written off-label for a 25-year-old with non-cancer related pain. So now that we've given you all this bad news, how can we mitigate the risk? Well, first, having written policies and procedures, understanding how you're managing patients, getting a written contract with the patient. It's important within a medical practice to designate a physician member of the practice to be really the champion of this and the leader. All too often in medical practices, the person that's assigned to compliance is someone that really doesn't have authority or hold sway over the actual prescribers in the practice. So it's very, very important to take this seriously and have a thought leader within the practice that can shepherd this process along and truly act to mitigate the risk. And everyone in the practice has to have the understanding that this process is to provide better patient care and at the same time protect the practice and physicians from these various liabilities. Effective training and education is key. How can a practice develop protocols, have certain standards, that just right as an initial step, just complying with the laws, understanding and complying with the laws in the state of New Jersey about prescribing opiates and what needs to be done. Enforcement of those standards within the practice. We understand, I've been in healthcare a long time and I've represented physicians for a very, very long time. I know how difficult it is to get everyone to agree and then everyone to comply with those standards, but there has to be accountability. And part of that accountability starts with having an internal mechanism to monitor what's going on. Very often, well-meaning programs are implemented and they start off with a great deal of passion and hope, and then tend to tail off as people are busy and they revert back to the old patterns. And prompt responses to detect offenses and development of corrective action plans. This is very important, especially when the government has gotten involved or before the government gets involved. We represent a lot of clients that have gotten either federal subpoenas or state investigations, and the ones that come out most successful are those that can demonstrate a good faith effort to comply with the law, even in situations where there has been some deviation from the standard of care, that it's not what the government calls reckless disregard. Kind of the ostrich with its head in the sand and not wanting to know what's going on in one's practice. So demonstration of good faith effort and documentation of those efforts to comply with the laws and the standard of care are tremendous risk mitigation strategies. Development of a comprehensive compliance plan for opiates. So ensure that alternative non-opioid treatments are considered. Make sure that the PDMP is consulted. Make sure that you're not dispensing medication to patients that are doctor shopping. Get that contract with the patient. Establish realistic goals. Make sure that the patient has a written consent. This is also very important on the regulatory side when it's time to discharge a patient that is not compliant. You don't want to, you run the risk of being found to have engaged in professional misconduct if you discharge a patient from the practice inappropriately. It can be seen as patient abandonment. So you want to have the right mechanism when you do get that uncooperative patient, when you do get that patient that is just seeking drugs, is just addicted. The other thing is get consults from other professionals. Make sure that you have within your plan referring patients for mental health consults, for addiction treatment, for addiction avoidance. Those types of other disciplines are very important. Also, the use of interventional pain physicians and advanced treatments to get the patients a different solution beyond opiates. Okay? Make sure that the physicians are conducting an appropriate history and physical exam. Do not, one of the things that the federal government has used a great deal is to prosecute physicians are physicians that have engaged in telehealth, who are writing prescriptions for controlled substances, but never seeing the patient, only seeing the patient via telehealth. That is a huge risk. Make sure that you assess the patient's baseline pain. Use the PEG score. Make sure your documentation of the patient's pain is accurate. Reassess the patient. Once you get past that initial acute phase, or that first 5-day treatment, when you prescribe patients for a longer opiate regimen, make sure that you're monitoring them. Make sure they come back for evaluation. Try using short-acting opioids with the lowest dose. Within the TERF-REMS prosecutions that have been going on, one of the areas that they have the government has looked at and challenged physicians on is, well, the on-label use says to start at 100 microgram dose, and you're starting at an 800. Why are you starting at the highest dose? And part of the reason behind that was that the manufacturers were pushing the higher dosages because those were more expensive. So you want to start with short-acting, lower dose. Never, ever renew a prescription without a patient visit. That is, you're just asking for trouble. And then at the end of the day, minimize the amount of time that patients are on opiates. Watch that judiciously. Don't, we represented a pain management physician who was a very good doctor who really cared about his patients, but he had a number of patients who were on opiates for a very extended period of time without any end game, for want of a better term. If there is no plan and there's no light at the end of the tunnel for getting a patient off of opiates, one needs to recognize that those are the cases that are going to be very problematic, and you need to address them. You need to come up with a strategy to avoid keeping those patients on opiates any longer than necessary. And again, in documentation is, I'm sure everybody on this call has heard this a million times, particularly from folks like Brian and the med mal carriers, is that documentation is key to everything. That, we were able to defend the pain management doctor who had kept patients on opiates for a long period of time because he had excellent documentation, and he had advised the patient to get surgery to correct or potentially correct the problem, and the patient refused over and over again to have surgery, refused interventional pain procedures. Ultimately, he discharged the patient, and he had impeccable documentation, and that's what saved him in an investigation by the BME. So documentation is always going to be your friend. And that said, I will open it up for questions.
Great. Thank you, John and Brian. Folks, if you can get your questions into me as quickly as possible, we're going to read them off one at a time. I'm going to start with actually the only submitted question at this point. My docs, orthopedic surgeons, are concerned now prescribing opioids for post-op pain based on the new guidelines. And while a referral to pain management docs is available, there is a concern for managing a patient that is appropriate based on the new guidelines. How can we protect ourselves?
Sure. I mean, that's really what most of this presentation was about, is that you have an orthopedic surgeon that performs a procedure and prescribes 5 days of an opiate for post-operative pain. The patient needs to come back and be reassessed. It doesn't mean that you can't provide them with another prescription for opiates. It's just that the initial one has to be a short duration and be reevaluated. Using these strategies, you know, an orthopedic surgeon who's assessing, who's assessing the patient is, in the short term, is the appropriate clinician to assess it, because that physician is going to know what the appropriate type of pain and level of pain is for the type of surgery that the patient received. And the orthopedic surgeon can look at that and objectively decide, well, does this patient just need a continued opioid regimen, or is there a surgical option? Do we need to have a re-op? Is it infection related, or is it truly a manifestation of the underlying surgery, which is very common with spinal surgery, is that, okay, the orthopedic surgeon has done what he could have done with within their discipline of surgery, and it's time to send the patient to an interventional pain physician. And as I said, the mitigation strategy there is to manage the patient appropriately within your clinical discipline, document, and get them to an interventional pain physician when appropriate.
Yeah, I would just have some kind of protocol in place, because a lot of the cases I'm seeing, and a lot of the physicians who I've spoken to, a few who are going through this process of potentially losing their license, are the ones that don't have that post-op component to it, where, obviously if you just came out of surgery, there's going to be plenty of situations, if not it's the standard, to prescribe these kind of medications. But to John's point, after the 5-day supply, reassess, and then if it's a considerable amount that you're giving that next time, make sure the patient comes back and then try and track it a little closer, and then go through all the strategies that John mentioned. But we're definitely, we're probably scaring people a little bit, and this is a huge problem, and it's not to be taken lightly. But so far, the cases that have come up have been some pretty hefty dosage of opioids, and without the justification, without the documented justification. So just keep that in mind.
Okay, thanks, Brian. The questions are starting to pour in now. So the next question, what about marijuana prescribing?
Okay, marijuana prescribing. That's a whole webinar onto itself, especially with the new administration in Washington. I always have to start off, and we represent folks that are dispensaries across the country for both medical marijuana and who have come to us with these questions. And it is a very difficult question. We have a number of pain management physicians that we represent in New Jersey that have asked us this question. And technically, marijuana is still a Schedule I, so under the Controlled Substance Act, it's illegal to even have it. The use of marijuana, however, in the state of New Jersey, I mean, we have a conflict between federal and state law, is allowed, and it is a viable alternative in the state of New Jersey. So if it is something that the physician deems an appropriate treatment for that patient, you can certainly, avail yourself to it, but understand that as of right now, at the federal level, the federal government is just using its enforcement discretion to not prosecute anyone for violation of the Controlled Substance Act. So you have to balance those conflicting interests when delving into medical marijuana. And then the other problem with medical marijuana, and this is not a commentary on the use of recreational marijuana or anything else, but you also now are going to attract people that don't really need medical marijuana, but are looking for it for other benefits. So it's a difficult area to prescribe in.
Okay, how do you recommend documenting checking of the PMP and how often?
Well, I think that's I think at any initial prescription, it needs to be looked at for that particular patient, and just documented in the medical record that the date and when it was reviewed. Certainly, anyone that is if there's objective criteria to suspect that a patient may be going to other physicians, as Brian pointed out, is that if you're getting inappropriate lab tests, if the concentration of the opiates is higher than what the physician would expect in the labs based on the patient's dosing, then I would check again. And again, it's the documentation in the medical record of when it was checked.
Okay, do these new laws have any effect on how physicians prescribe in the inpatient hospital setting?
Well, that is a really good question, and it's that's not something that we have actually thought about, to be honest with you. Conceptually, if for the physician that's writing a prescription for discharge, it's certainly a concern. I doubt that these laws that as written about prescribing or written prescriptions apply to the hospital, because you're very often given other types of drugs in other types of scenarios. But there's still, from a malpractice risk, I think there's still a conceivable risk. I'd like to hear Brian's thought on this. But if a patient is in the hospital for an extended period of time, and you're maintaining that patient on opiates and then sending them out the door, even with a 5-day prescription, knowing that they are now potentially addicted to opiates, I think that you're running a risk there.
Well, it's especially important to understand the patient's history, and you may be seeing some more publicity on these patient directives, some legislation around it. There are a lot of groups out there now encouraging patients to notify their physicians and keep it in their record if they're just adverse to opiates in general, or more importantly, if they have a history of addiction. And I think those are the things you need to be aware of when they're coming in, because God forbid you have a patient who just got over a bad battle with addiction and comes to the emergency room, under some sort of emergency situation, and you were able to ascertain from the record the history, but you just didn't, or for whatever reason it was missed, then it's a problem. And then, to John's point, if they're there for an extended period of time, and it's not the simplest thing after a week to be on heavy dosages of narcotics have a discharge plan in place, even if there's a limitation on what you can prescribe for discharge. Keep an eye on that patient if they're going to go to another physician, particularly in your network, or someone you may refer them to post-op, or to try and keep an eye on them, because it is a liability risk, and it goes back to what I was saying. These are the cases that the plaintiff attorneys are all over right now, because they want that jury to see that this patient was fine, and then all these prescriptions were made, and then all these problems happen.
Okay. Next question. While I understand the major focus is on certain opioid drugs, the bill itself is vague. Will the use of medicines like tramadol or cough meds with opioids also be included in the list of opioids?
Well, I think the way that the law is written, and many laws are written to be particularly vague, is that let me stop for a second, is that it also depends on what governmental entity is looking at the problem. So basically you have several different areas of risk. You have the federal government and their concerns. You have the state, which is generally enforcing through the professional licensing boards. You also have, the payers, particularly, Medicare, Medicaid, things like that. And now private insurers that will look to take money back or point out that, something was written for inappropriately, so we're not going to pay for it. And then, you have the issue with the plaintiff's lawyers. I think the greatest risk is from the plaintiff lawyers on those types of making a very broad reading of what the law means. So I would give opioids a wide berth and include any type of opioids that can potentially, people become addicted on all sorts of things. So writing for anything that is potentially addictive, and although they're talking about opioids here, you can see it's not that far a stretch to go to other scheduled drugs, at least on the plaintiff litigation side, and say, well, you had this law, you're supposed to be monitoring a patient for opioids. That's the standard of care, but you're writing for these other Schedule II drugs that are equally addicting, and you have deviated from the standard of care. So I think it's a pretty broad reading that this should be given.
Okay, I want to clarify that the new guidelines start May 15th. How do you feel about a consent each patient needs to sign reflecting the new law?
Well, any consent is really is helpful for documentation. As I said, documentation is always helpful. It's more important, though, as with any type of informed consent with a patient, is to also make sure that the patient is actually signing for an informed consent and understands what's going on. So communicating to the patient is important. Getting a informed consent as far as the 5-day prescribing and the opiates and the risk of opiates, I think is important. I think what's even more important, though, and what creates an even greater risk, and where we have actually, for some clients, developed consent forms and educational forms, that it's in the area of prescribing naloxone and educating the family and providing them with a prescription for naloxone, where the consent basically says, I've received, instruction by my physician's office on the use of naloxone. I have been trained in how, I understand how to recognize an opiate overdose, and I have received a prescription for naloxone, and I'm aware of the actions to take if I witness an opioid overdose. I mean, I think that's one of the more important consent forms to have a patient sign and be in the patient's medical record.
I always think consent forms are the best way to memorialize a practice's policy and procedure. And if you can educate everyone in the practice to understand when the form should be used and how to describe it to a patient, it's so invaluable, because it takes all these issues. I wouldn't have just one consent to say, here's the law, be aware of it, but I think that needs to be a big part of the form to say, here are the guidelines that we follow, or, here's our treatment path or our discharge advice, and you should sign off on all these things. And if they say, well, why would you do it this way? Well, for one, it's the law, and for two, we think it's a best practice, and it's what our practice follows. So I definitely encourage everyone to have that kind of documentation to give to patients and have them sign it. But it's just as important to make sure all the professionals are in a position to describe the forms in a way that the patients understand.
And gentlemen, to the first part of that question, to clarify, the new guidelines start on May 15th.
That was part of the question. So yeah, I guess that's when they first take effect, correct?
Okay. Next question. We have patients in our practice who have been on long-term pain medication. What is the best way going forward to manage these patients? Focus on continued documentation and ensure we have a contract. Any other suggestions?
This is a tough one, and I'm anxious to hear John's, but this is something that I mentioned at the beginning. It's really hard for us to cover everything, because as part of this law, there's going to be mandated treatment paid for by the payers. So if it's possible to get these patients into these programs, great. But the reality is a lot of them are still not going to have insurance. A lot of them are not going to be able to afford co-pays and deductibles associated with the treatment. So it's a very difficult issue, and something I would personally want to spend a little bit more time on. I'll kick it over to John, but we'll always fall back to just documentation. Try and do what you think is medically reasonable and medically justified, and just document it.
Yeah, I think that if you're in a situation where, the new guidelines, one of the major emphasis is on the initial prescription, and again, I think the greater risk is from the med-mal side and the deviation of standard of care, and from the BME. About, in the BME, notwithstanding the new law, has the latitude to evaluate any patient's treatment and say, this is inappropriate. This violates the standard of the New Jersey Board of Medical Examiners. And when folks like Brian and I have to go down that path, this is what happens. The state gets an expert who is another physician that says, I reviewed the medical record, and this is entirely inappropriate what was done, or what the ongoing treatment. So I think that for any patients that you have that have been on long-term opiate management, is that they have to be individually evaluated. Each case has to be looked at and said, why is this patient still on the Medicaid? It's still on opiates. What are the alternatives? And look at them in the point of time that they're at, just like any patient that you were starting with from the very beginning, and saying, what is our plan of action? So if you have somebody that's been on opiates for 7 months, 8 months, a year, and you need to look at that and say, well, what is our plan? Do we have a plan? Or are we just going to keep writing prescriptions? Because if you're just writing prescriptions, that's what, that's precisely what all these laws and guidelines are meant to put an end to. So that's the way that I would approach it, is go through and look at the patient's history, and start with the patients that are at the greatest risk, and reevaluate how you're managing that patient, how you're going to manage that patient going forward. Bring the patient in. If you don't have a contract with that patient, you say, well, here's the plan. to get you off of opiates and, have them sign that contract and get them, whatever help they need and utilize whatever other clinical disciplines is appropriate for that case.
Okay, next question. After the 5-day period, in order to write more, don't you need to have a conversation with the patient and indicate the risk of addiction and document the conversation?
I'm sorry, what was that second part? Could you just read the question again?
Yeah, after the 5-day period, in order to write more, don't you need to have a conversation with the patient and indicate the risks of addiction and document that conversation?
Yes.
Okay. Down to the last couple now. What about Schedule II drugs that are not opioids, such as stimulants like Adderall? Are they covered under this law? Do we have to follow the same guidelines?
Well, I kind of answered that question a little bit earlier. It's not, the black letter law doesn't include other Schedule IIs, but as the Board of Medical Examiners certainly has wide discretion, and plaintiffs' attorneys can use it as just to as an analog and say, well, this other drug, whatever the other drug is has this documented risk. Doctor, why didn't you notify the patient of the risks of addiction or the risks of overdose or whatever the case may be. So that's where I think the vulnerability is. And any law that is created essentially creates an opportunity for plaintiffs' lawyers to come up with novel causes of action to demonstrate a deviation from the standard of care.
Is it recommended to print out the New Jersey PMP report and scan it into the patient's chart?
Yeah, I mean, look, the bottom line is this, is that everything that we do kind of comes down to reasonableness and how it's going to impact the operations. If it's, all things being equal, if it's a relatively easy process and is not going to overwhelm your office, yeah, it's probably a great idea to include that in the medical record. But I always, no matter what ancillary, this is just a general observation or recommendation, is that any time that you're incorporating any third-party documents into a medical record, that there's always a note, there's always an indication in the progress note or whatever your chart, whatever part of your chart it's appropriate, is to document that says that the database was accessed and the patient had not seen any other, not sought opioids from any other patient. That's always something to have that in writing within the chart is always an important step, because the third party, the third party printout can be challenged. It can say it wasn't done contemporaneously. It's, it's not, its evidentiary value is not the same as a notation in the medical record. So really both is the best.
Okay, I'm going to go with the last 3 questions here, folks, and then I'm just going to encourage everyone to attend the seminars in South Jersey and North Jersey the end of this month. So here's the last 3. Following the question on hospital stays, what about nursing homes and other similar types of facilities?
Yeah, I mean, again, we can't cover everything, but I think the touchstone is that this is directed at physician prescribing. So I think, again, the liability is that, you have to, physicians have to be objective and comport with the standard of care. So the same thing, you have somebody that's in a long-term care facility because they were in a car accident or they have some other type of debilitating injury, and they've been on opiates for 3 months in the hospital and 8 months in a nursing home, and you just discharge them without some type of intelligently crafted plan, I think you're exposing yourself to both the facility and the physician to a tremendous amount of liability, that you're going to expect that you hand somebody a prescription for a 5-day supply of opiates and roll them out the door, that's not going to be viewed as a deviation from the standard of care, is highly unlikely.
Can you also tell us about the delegate process under the New Jersey PMP? Several physicians have asked who can be a delegate to enroll patients on the website.
Yeah, I can't answer that off the top of my head. That's something that, Brian, I don't know if we have a mechanism to get back to folks with that answer.
Sure. Dawn, do you know who asked that, Dawn?
Yes, I can get that information over to you.
Yeah, so if you
we'll
send
follow
that
up on it.
question to us, we'll research it and get that exact answer for you.
Okay, great. And the last question, isn't letting everyone get naloxone dangerous because when not used for heroin overdose, it's a dangerous drug in itself?
That answer is yes. And there are some physicians, any drug is dangerous if used incorrectly. And you know, naloxone is not a benign drug. It's not, even in opiates or perceived opiate overdoses, if it's not administered correctly, can be harmful. But it is relatively benign, meaning that if you give naloxone, particularly the nasal spray, to someone that's not an opiate overdose, it has a minimal effect. So this comes down to two things. Number one, the folks that are getting naloxone need to be trained. I mean, it's not an exhaustive training process. It's, you know, a relatively short, you know, 15-minute type thing. But it's also the risk, and that's why the state has created the safe harbor, the Good Samaritan type law, because the risk of not giving somebody naloxone is so outweighed by the consequences of, I mean, the consequences of not giving it to a patient are so outweighed by the risk of not giving it. Is just incredible. And giving it to a patient that's not totally overdosed or is fairly minimal in the greater scheme of things. So from a liability standpoint, because of the safe harbor, you're not going to be liable if it's given in good faith, and that's really the intent here. And we have a long history, you know, states have a long history with Good Samaritan laws, you know, that there is a, you know, that you know, a patient at risk invites rescue, and if the rescuer is a layperson and acting in good faith, you know, they don't have a duty to act. So it's very hard to prosecute or find fault with somebody that would be administering naloxone in a good faith manner to a patient.
Okay, thank you very much. And folks, I can't stress enough, please, we'll be delving into this topic with several other experts as well as John and Brian again on April 28th in Deptford and May 5th in Islin. You can register right from the website, or you can always give us a call. Thank you again so much, and have a great day, everyone.